Welcome back. We now have joining us via Zoom Dr. Nikkiah Forbes, an infectious disease specialist who has been, as I'm sure you all know, has been working very closely with the team in order to fight COVID-19. Good afternoon to you, Dr. Forbes.
Good afternoon, Julian. Hello, Bahamas. It's always a pleasure to be here on your show, Julian.
Thank you. Up to yesterday, 33 confirmed cases, 5 recovered cases, 339 people in quarantine, and sadly 5 deaths. All of this in consideration, how do you feel, you and other health officials feel, we are progressing in the COVID-19 fight?
Well, we're certainly seeing new cases, an increasing amount of cases. Sadly, we have lost 5 persons from the COVID-19, and there are a number of people in quarantine in their homes and in some facilities.
Now, we keep hearing about a peak. Are we anywhere near that peak, you think?
What we can say is that we're seeing an increased number of cases. We think that we are in a surge, but at this time, we have not overcome the capacity for our health system to deal with these cases. But yes, we are seeing an increased number of cases as time goes on from since the first case.
Great. And you mentioned our capacity. How is our capacity? We hear that we're getting more test kits. We're looking at rapid testing. We are building our capacity?
We have established places within our institutions. That's the Princess Margaret Hospital, and Doctors Hospital on Blake Road has been nationalized to deal with COVID-19 cases and to investigate people who are coming to the health system with cough and fever. We are continuing to make available health facilities in order to meet what we expect to be a surge. We are not at our current capacity. We will know that we're at our capacity when the number of cases have exceeded what we can do in terms of offering care. We're making available some 80 plus to 100 beds that the minister has spoken about previously. And we are actively continuing our work to meet the demands of patients presenting to us for care.
Great. Now we're hearing...
As it relates to testing is ongoing. We are increasing the testing capacity also. You have heard that there are rapid tests that are being validated in country right now. Those are blood tests that can tell if someone has COVID-19 in the recent period within about 5 days. That is an acute infection and longer. And so we're needing to validate those tests in country at this time. The gold standard test is the PCR test that's being done at the National Reference Lab.
The rapid test, how quickly would you get the results from that?
They're still being validated, so that information we are needing to see what would happen when those tests are available in real time.
Now we're hearing a lot about different treatments that are happening around the world. Plasma treatments, an HIV drug treatment, and of course you are the director of the National HIV/AIDS program. I'm sure you must find that very interesting. Anti-malarials, and then antibody testing. Are we anywhere near to doing testing like that? Is it something that you see us doing in the future?
Let me start with the last part of your question. That's the antibody tests?
Yes.
That's exactly what's being tested for in the rapid tests.
Okay.
Usually those tests are available in a short period of time, hours, for example. So as it relates to treatments for COVID-19, in that this is a new virus, there is no approved treatment that is guaranteed to work in terms of the best quality evidence that scientists look at. We look at a large number of patients that are tested. We look at if they work, regardless of whether the doctor knows what the treatment is and the patient knows what the treatment is. And we look at large numbers and say that it absolutely works without a doubt, not by chance. No such evidence exists at this time. The position of both the Centers for Disease Control, US experts, the World Health Organization, is that there is no proven treatment at this time, and the treatment is supportive, meaning that we will give antipyretics, we give other medicines to reduce symptoms, we can support respiratory distress or persons who are having difficulty breathing, we can support that. There are investigational treatments You have mentioned some of these. This includes HIV drugs. It includes drugs that are in clinical trials now, a drug called remdesivir through Gilead Sciences. It includes interferon. It includes chloroquine, which is an anti-malarial drug. It includes hydroxychloroquine, which is used in rheumatoid arthritis and other conditions. Those have been put forward to be used, including plasma exchange from plasma therapy from people who have had COVID-19 and survived. All of those have been put forward, and in some small groups of patients, they've been used. For example, the plasma was used in 5 patients under specific conditions. However, when we look at the information coming back from these studies, they're not robust studies. Just this morning, someone talked about the drug called hydroxychloroquine. And when you look at that paper, so scientists, what we do is we look at papers and we say, okay, was this valid or was it confounded by other factors? It was actually not a good quality study because the other patients who quote unquote did not do well on the drug were not actually tested afterward to see whether or not they would have cleared COVID-19, like the persons that were tutored to have gotten better. So we have to be very, very careful when we consider what are we saying as experts in terms of how COVID-19 can be treated. There are other factors. There are other factors that go beyond science. Sometimes people feel comfortable. There are other motivating factors for why someone could say that this treatment could be effective. We have to be careful because usually for disease conditions, for treatments to be approved, they have to work without a doubt. And there's a process to that. When we skip that process, we know that bad things can happen. Theoretically, some medications may work, but they may not work that way when given to persons with a condition. Sometimes they cause harm. In other viral infections, there were medications that were theoretically supposed to work, but they actually made persons worse. And so that's why we have to remember that we have to practice good medicine. One thing about practicing good medicine is first, you don't do your patient harm. So you don't want to just give someone an experimental therapy. You don't want to just stack multiple experimental therapies on your patient. It can do harm. Now, on the other hand, it behooves us to have good information for this infection, this new infection that has high mortality. At this time, clinical trials are underway that physicians worldwide, if giving medications for compassionate use, can forward that information into the collective pool of knowledge so that we can know within a short period of time if these drugs can in fact can be beneficial to patients with COVID-19. That is where we are. But where we stand scientifically is that there is no proven medication that can make a person better who has COVID-19, that can reduce their symptoms, and that can reduce their chance of dying. We do not know that at this time. And that is where we are as a scientific community. Any other use of these medications would be considered compassionate use, and some of these would be off-label.
Is that because the virus is mutating? Is that because the virus is mutating?
No, I wouldn't say that the virus is mutating. It has to do with the fact that this is a new virus and there's no proven efficacious treatment at this time, not because the virus is mutating. So there have 8 strains of the virus that have been reported lately, I think within the last week or so, but scientists say that that doesn't confer a worsened course, or that people with these different strains may have a worsened course when I last read this.
Other than being a virus, are there any other than being a virus, are there any similarities to HIV, COVID-19 and HIV?
No, these viruses are different. So coronavirus is a coronavirus. It's encapsulated. HIV is a different virus. It's a retrovirus. Okay,
good. Let's turn to contract tracing. How's our contract tracing go? We heard the Prime Minister speak about super spreaders yesterday. That must be really frightening for everyone.
Contact tracing. Contact tracing is for those persons that are lab confirmed with COVID-19. We will be needing to get the contacts for those persons, the close contacts, because there is a strategy to help control this infection. You find the contacts, you put those contacts in quarantine, and there can be testing and monitoring them for symptoms. That's going very well. I want to congratulate our surveillance team at the Ministry of Health. They're working very, very hard to get that done, to get those persons in quarantine, and to make sure that we have that information in a very, very short period of time so that we can also map where contacts are and do necessary public health work and containment measures. When we think about a super spreader, there's a definition for that in the infectious disease or public health world. That is one person who can spread the infection to multiple people. Now, how can that happen? You might not know that you have COVID-19. Remember, you can have asymptomatic people spreading COVID-19, or you might have mild symptoms, or even be feeling sick and you're not curbing your regular activity and staying home and self-isolating and keeping yourself away from other people. You will then infect that person. Will then infect multiple other people. I'll give you an example of a super spreader. In one country, one patient went ahead and went to church, a large church service, and infected about 650 people approximately. And that person had actually refused to be tested. So we're very concerned about things like that. We have to remember that we have to follow the instructions. The instructions being everyone should stay at home unless you're essential services, and practice respiratory hygiene, hand washing, do not gather. Those are all very important. I know we can do this, and if we can do this well, countries that did that well, they saw flattening of their curves, and they were able to control the epidemic with few cases.